a reconstruction together. We've also got fantastic speakers who've been lined up for this event, and I thank both of them to actually get these speakers on board to help us with this session. And I'll get them to introduce all the speakers to you in a few minutes. We'll try and make it as interactive as possible because this is being broadcasted. So if there are any questions, do post them. And if you can't join us today, you can access this on our on-demand platform as well. So once again, a big thank you to you, Nico and Germán, and to all the speakers for making this event a reality. And thank you very much from all of us here at SICOT.
So, thank you, Vikas. I would like to say thank you, everyone. We continue. Veamos si es que la pasamos. Acá. So, good morning. My name is Germán Salazar, and today I would like to talk about treatment of Paprosky type 1 acetabular defects. I don't have any relationship with commercial or non-profit organizations. I will start with acetabular component loosening. At least 2% of acetabular component lose after 10 years, and 24% acetabular component lose after 15 years. That is a fact. Then talk about acetabular defect classification systems. There are a lot of classifications like Paprosky, Gross, AAOS, Harris, Lombardi. Campbell analyzed the reliability of the Paprosky, Gross, and AAOS classification systems. In this study, low reliability was demonstrated in the 3 systems and high inter-observer variability. The system of Paprosky classification is the most practical based on acetabular bone loss and reconstruction methods. The Paprosky system uses preoperative radiographs to classify defects by the amount of acetabular component migration and the status of the acetabular supporting structures, including the anterior and posterior columns, the superior weight-bearing dome, and the middle wall. It is based primarily on the presence or absence of an intact acetabular rim and its ability to provide rigid support for an implanted acetabular component. The amount of bone loss and migration of the acetabular component are critical elements in planning an acetabular revision. I show you some indication for acetabular revision, like implant fracture, hip instability, periprosthetic joint infection, adverse local soft tissue reaction, tenonosis, osteolysis, aseptic loosening, limb length discrepancy. I would like to continue with contraindications, like severe infection and low life expectancy. Let me tell you about planning. Preoperative planning is the first and most important step when performing revision hip arthroplasty. We need to identify implant designs, labs like CBC, CRP, ESR, DD, metal levels like cobalt and chromium levels, aspiration, biochem markers like leukocyte esterase test and alpha defensin test, biochem profile, nutritional profile. I would like to discuss about Paprosky type 1 defects have minimal focal bone loss with maintenance of the hemispheric shape of the acetabulum. The supporting structures, including the acetabular walls and columns, are intact and with no hip center migration. You can see ischem, teardrop, colors line, and no hip center migration. I don't talk about type 2 defects because next speech is about it, but I quickly show you Paprosky 2A defect, Paprosky 2B defect, and Paprosky 2C defects. So what to do with acetabular defects? We must have surgical strategy. We know about approach, microbiological culture, aspiration testing, appropriate instruments, multiple implants. So interesting about cementing. High incidence of radiological loosening and revisions. Without trabecular bond, it is very difficult to achieve interdigitation with acrylic cement. Amstuds analyzed 66 revisions of cemented acetabular cups and reported that 10% of acetabular cups demonstrated a component radiolucent line in the immediate postoperative period, after an average follow-up period of only 2.5 years. This line had increased to 71% on revision caps. In this paper, in young patients 55 years or younger, after an average of 6 years of follow-up, reported an acetabular loosening rate of 51%. The clinical result was excellent or satisfactory for 79 hips, 91%. However, at the latest radiographic assessment, 26 sockets were loose. Of the 50 hips that had good bone stock, only slight enlargement of the acetabulum or local defects involving only one wall. Before the revision, 14% had loosening of the socket compared with 51% of the 37 that had poor bone stock. Massive or global collapse of the acetabulum and defects involving at least two walls. The relationship between loosening and the quality of the bone stock before the revision was highly significant. In this algorithm to diagnose or manage type 1 or 2 defects with a CR rise less than 2 cm, in case of type 1, we can use hemispherical cup plus screws and grafting if required. How about improving the cementation technique? Callahan, in a series of patients operated on with the use of modern cement techniques, they found that the prevalence of mechanical failure after revision had not improved. 9% of the caps had migrated at 19.4%, showed progressive formation of radiolucent lines at 4 years. If acetabular components with continuous radiolucent lines are included, 34.2% of the revised acetabulums were radiologically loose. I would like to talk about non-cemented biological fixation. The most encouraging results: cement hemispheric components with a porous coating with or without bone graft. In acetabular defects of less than 30%, I mean Paprosky types 1 and 2, porous hemispherical cement cups fixed with screws give good results. Modern trabecular metal dressings improve these good results. Morselized allografts are useful for filling cavitary defects. Paprosky and Sekundiak report that absence of aseptic loosening in a series of 125 patients with Paprosky type 1 and type 2 bone defects with a mean follow-up of 61.6 years. Now I would like to discuss about hemispherical cup plus porous metal. Study from 2018 compares non-cemented porous metal acetabular components plus 4 screws is more stable and has less micromotion than non-cemented acetabular component plus 2 screws in 2B defects. Let me tell you about non-cemented cup plus structural graft. Structural and morselized allograft in combination with a cementless cup is a viable option for reconstructing acetabular defects. This is true for types 2 and 3. On the issue of jumbo caps plus structural or morselized graft are effective in restoring RC with a good short-term results and good primary and secondary stability. And finally, to take home messages, bone preservation and cementless technique. So much, thank you.
Thank you so much, Dr. Salazar. Right now, we're trying to introduce Dr. Willy Molina. He's from Bolivia. He's going to talk about type 2 acetabular defects, planifications, and how to solve them.
Thank you, Nicolás. Acetabular defect type 2, planning and how to solve them. Given the ground incidence of DHA, the revision of acetabular component is now common and frequent procedure. The great majority of failure occur due to septic losing. Other causes include infection, recurrent dislocation, prosthetic fracture. The increasing THA's incidence has determined what develop different techniques for acetabular reconstruction. These techniques include these and those of the following: cement acetabular cup, no acetabular component with porous lining and fixed with a screw. A small component with porous line placed and high center rotation, ring or metal case, with or without bone graft. The medium dam result for some of these techniques are just and become available. The use of cement in acetabular revision over the short to medium dam show high incidence or radiolucence. No cemented acetabular component fixed with screw with or without bone graft. All have shown promising results. No cement acetabular component continue being the preferred option in severe European center. A structural graft with the objective or restrain the center of the hip to its anatomic position. The use of special component such as reinforcing rings continue being a topic of discussion in hip reconstruction surgery. THA revision using no cement hemisphere acetabular components have shown good results over the short and the medium dam. Several classifications describing acetabular bone defect have been proposed: EOS, Ing, Glassman, Paprosky, Gross. Great studies then understand the bone defects up to 40% consequently. These defects need to be reclassified during the operation is safe. The most commonly classified used are AAOS and Paprosky. This first the most descriptive. The second tries to quantify the bone and thus get and orient the treatment. Overall bone defects that affect at least 50% of the acetabulum are considered slight or moderate. Gross bone defects are considered to be affecting more 15 of the acetabulum. This is classification and AOS on the Paprosky. This is classification the Paprosky. Type 2, 2A, superior, 2B, defect superior lateral, 2C, defect medial. Structure support of the acetabulum. These support structures are used to determine a Paprosky classification. Here we have a routine AP X-ray of the pelvis. Now, the deer space structure, medial wall, red arrow. Looking for defects. The migration of the hip center, superior down wall green box. The color line, anterior column, medial wall, blue lined. Look for the presence of absence of the ischial joist, yellow box. Demonstration case, Paprosky type 1, patient 80 years old, osteoporosis patient, solved with a cement cap. Demonstration, type 2, patient 71 years old, case solved with a porous, no cement cap fixed on a screen. Operating room and table. Nobody in, nobody out. Drive table, room temperature 20, prepared topical tranexamic, anesthesia in reins. 2 gentamicin vials and 2 liters saline solutions, 3 vials tranexamic, diluted in 80 cc saline solution, bupivacaine plus ketorolac, 2 vials of bupi, 1 vial of ketorolac. Goes for secondary fields. Secondary fields, 1 side and healing, 1 healing 1 week later, clean and dry wound 2 weeks later. Case 1, 24 years old, female patient, CAT scan, post-trauma acetabular defect, Paprosky type 2, with an intra-articular screw installing previous pelvic injury. In the operation room, deforming the femoral head, removal of screw, friction superfice ceramic at head, checking in THA stability, control X-ray, CAC solve, no cemented cap fixed with a screw. First mount, third mount with physiotherapy. Case 2, case de Luciano Lucindo in Brazil, male patient, 82 years old, 40 years post-op, Paprosky type 2 with a porous no cement cap fixed with screw. Case 3, male patient, 16 years, Paprosky type 2, unsolved with porous no cement cup fixed with screw plus an acetabular wedge. Thank you.
Thank you, Dr. Willy. Right now, we're going to present Dr. Marco Carrión from Cuenca, Ecuador. He's going to talk about Paprosky type 3 acetabular defects. Thank you, Dr. Marco.
Thank you, Nicolás. Good morning, everyone. Now I'm going to talk about the type 3 acetabular defects. I am Marco Carrión from Cuenca. These are my disclosures. Well, we already have talked about the classification proposed by Wayne Paprosky and his team. He evaluated on 147 cemented caps. So it's important to understand that this work was done in cemented caps. And it's supposed that the cementless caps can fail in a different way. They checked the X-rays and they saw that some of the defects can change when you go to the surgery and you really see the defects. So the final classification will be done after the surgery. So we have talked about the type 1, the good defects, the type 2, the ugly defects, and now we are going to talk about the type 3, the bad defects. As we already saw, these are the big ones. There's an important ischial lysis, medial migration, teardrop lysis, and superior migration. In the classic work of Teleria, so we already saw that there are 4 important lines to take in account: the migration, the teardrop, the color line, and the ischial lysis. So in this case, the type 3 defect is defined by the superior migration of the center of rotation of the hip of more than 2 centimeters on a migration of the acetabular component of more than 3 centimeters. We need to remember that the aseptic loosening is the main cause of revisions still. There are other causes like infection, dislocation, or periprosthetic fractures, but still we see a lot of aseptic loosening, and that's the principal cause of the big defects. First, we need to evaluate the patient after a thorough history and physical exam to check how many surgeries the patient has had, to see the scars, to check the lymph leg discrepancy, and also lab tests to rule out infection. Remember always that the most important part is to rule out infection. If we are in adult, we need to aspirate that joint and also to do some tests, especially leukocyte count and differential, cultures and sensitivity, and tests like alpha defensin to check if there's any suspicion of infection. Good X-rays, a pelvic X-ray, complete femur X-rays in AP and lateral views. We can add also the judeo-oblique views, the iliac and obturator views, also X-rays of whole length of the extremities in order to check leg length discrepancies and the angles of the joints. It's mandatory to have a good CT scan also to check the magnitude of the defects, also to check if there's problems with the vascular components of the pelvis. And in some rare cases, we need an MRI to check, for example, for pseudotumors or for abductor mechanism deficiencies. And after the surgery, we will be able to decide which type of defect we really operated on. The treatment, it has to take in account factors of the patient, like age, comorbidities, and expectations. It's not the same to have a patient that is walking and that a patient that's bedridden or has a lot of medical problems. So in some of these cases, we will consider non-operative treatment also, or just a treatment like a cement spacer or a Gierleston procedure. The goals of acetabular revisions are preserve the bone stock, not removing more bone that is necessary, restore the hip center of rotation and the hip biomechanics, try to restore the limb length and obtain solid fixation of the new implant to host bone. Remember that failing to plan is planning to fail. Hope is not a plan, so we need to enter to the operating room with everything ready to do a good surgery. First, wide exposure, not minimal invasive surgery. Component extraction without removing excess bone, removing the fibrous tissue in order to have a bleeding bony bed and evaluate the bone defects. There are several options to deal with type 3 acetabular defects. For example, bone graft usually is not enough by itself. It can be structural or morcellized, and it also can be mixed with antibiotic in order to prevent infections or to treat current infections. In the past, we used a lot of structural bone allograft, but right now we are using it less because of problems like bone resorption, infection, and component loosening. There are some studies like this one of Lee in 74 patients. They have uncontained acetabular defects that covered up to the half of the acetabulum bone, and they had a survivorship of just 67% at 15 years or 61% at 20 years. So not so good results with just structural bone allograft. For example, this case, it's an old case, female, 53 years old, bilateral total hip arthroplasty 20 years ago. She was operated on in other hospital for femoral aseptic loosening, and then the acetabular component became loose. She was revised, and then it again became loose because she had cemented fixation with a reinforcement ring. And then I put on a structural bone allograft. You can see to the right of the picture, there's a huge defect covered with bone, but there was good posterior superior and anterior superior bone in order to fix the cap. This is the result, negative cultures and good fixation to host bone. and at 5 years, it's still working. The bone graft has been replaced, especially for the porous metal augments. These are made of titanium or tantalum, two very strong metals, and also that can be printed or designed in porous conformations. These augments are fixed with screws. They are cemented to the cap, so they are fixed to the bone, but they have to form just one block with the porous cap. They can restore the acetabular rimmer walls, and they can convert an uncontained defect to a contained one. For example, in this work by Wang, 26 patients with Paprosky 2 and 3 defects, they had 100% survival at 4 years, and the Harris hip score improved from 36 to 81 points over 100. This is a case, woman, 22 years old. She had a motorcycle accident, multiple hip surgeries, an infection treated with a spacer, and also a huge defect proximal to the native cap. Here you can see that the patient, after the debridement, an acetabular augment was screwed to the superior part of the acetabulum, and then a porous cap was located in place. This is the final result with a huge buttress augment holding the cap in position and cemented to the cap. Cages. Cages are also an old treatment. It has results from many years ago. You have to put some compact morcellized bone graft and then a cage or a reinforcement ring. And it's fixed with screws, and then you cement a liner inside the cap. There are many models of the cage. Maybe you know some of these ones: Schneider, Gangs, Kerbul, etc. The problems with cages that they can break, they can loosen, so they have a complication rate of about 50 to 60%. So that's the reason we don't use them much anymore. For example, in this work of Goodman, they have 24% of failure at 4.6 years. That's a short term. But they are still an option for old patients that who don't have a long life expectancy. This is an old case also, male, 73 years old. He had a bilateral bipolar hip arthroplasty, performed 16 years ago. So after removing the head inside the pelvic and also filling it with bone graft, we put a cemented Schneider cage and also a polyliner with a regular head. This is the post-op X-ray, and also after the surgery of the other hip, and at 4 years, the patient was still working fine. Cap cage is another option. That's a new one. It combines the advantage of the porous metal with the initial stability of the cage. So this bridges the defect until biological healing occurs. In the porous metals, if it's not completely stable, we can supplement with a cage and then cement the cage to the cap and to the liner. Or you can use also a half cage. There are many systems that come ready with this. In these works, for example, at a follow-up of 44 months, there was just an 11% failure rate, and also in these other works, 7% failure at 5 years and 15 at 10 years. So these are results that we can rely on. For example, there's a cap cage there. And lastly, the custom implants, they can be used for these type 3 defects. You just get a CT scan of the pelvic patient, then design between the surgeon and the engineer an implant that fits the patient and also that meets the demands with 1, 2, or 3 flanges that can go to the ilium, ischium, or pubis, and you decide where the screws will go. It's expensive, and it takes some weeks in order to produce it. There are some works, like this one from the Mayo Clinic, in 57 patients at 5.5 years. They still have revision 30%. Not everyone for aseptic loosening, but we know these are complex cases, so they have just 70% success globally. Another work from the Martino at 4.7 years, they have a complication rate of 29%, all-cause revision of 17%. This includes not just loosening, this includes also dislocations, infections, and other problems. This is a case of the Mayo Clinic. They developed this type of custom-made implants, and that's the final result. So, finally, type 3 acetabular defects are complex problems that we sometimes have to face. Always have more than one option available in the operating room. Ask for bone graft in advance. Porous metal augments are an excellent defect filler. Have cages and plates ready. If nothing seems to work, think of custom implants. Thank you very much.
Thank you, Dr. Marco. He's a view of people from all over the world listening to this meeting. Right now, I'm proud to present Dr. Erwin Cah Chan. He's talking about the pelvic disruption treated with grafts and cup cage. Thank you, Erwin.
Okay. Thanks again. Thank you, Pablo. Thank you, Nicolás, all the committee. Okay. So, we are going to talking about the pelvic discontinuity. Use a cup cage with a low graft clinical cage. Was a significantly clinical case because was a female. Okay. Female patient, 60 years old, businesswoman, morbid obesity, this is very important, 3 previous surgeries. In the history, 55 years ago, was made a Chiaris osteotomy. The diagnosis in that moment, hip dysplasia, okay? Underwent surgery 13 years ago for internal hip pain. This the X-ray in that moment. I think that wasn't a good decision because these kind of devices are a metal-on-metal couple, and female cases not a good indications. However, the patients can working about, I think, 6 or 7 years without pain. No intervention 2 years ago, total removal of the system due to pain and functional limitation, reconstruction during the same surgical procedure, cemented dual mobility cup, Mueller ring for reinforcement, and structural bone graft support, uncemented conventional stem. But this is the problem. Can you see all the damage? And the pelvic discontinuity and the pelvic disruption. In the classification of Paprosky's, I think that it's not 3B, it's beyond the 3B, okay? Discussion options. Current options for the management of the massive bone loss or osteolytic pelvic discontinuity in revision total hip replacement include: 1, the use of porous metal, augments with a porous metal acetabular component, standard in ilioischial cage, reconstruction, and a cup cage construct with a porous metal acetabular component, and inside cage fixed proximally and distally bulk acetabular allograft with plating and custom 3-phalange component. We decide for this cup cage construct. In this revision article, we can see about these examples of the evolution in each cases that they show him. For example, case 1, and they use the cup cage with a reinforcement ring. My colleague before me talks about these kind of devices that we can use in these cases. And the report results with cup cage constructions in revision hip arthroplasty. You can see it by author year, number of hips, minimum follow-up. This is the principal means for they show the results and the success rates. Okay, in that moment condition, when she comes with us, she consulted for intense pain and functional limitation, which prevented her from walking, and 2 weeks with a very, very lot pain. She also reported shortening of the limb.
Yeah.
You can observe. And particularly, she is a very, very, very heavy woman. This is very important. How you can see, this is difficult for the support of the walking. And the left pelvic limb shows approximately 5 centimeters of limb shortening with pain in both active and passive mobilization. Distally, there are no signs of neurovascular compromise, and capillary refills is immediately. No problem with the preservation of the limb. This is the X-ray in that moment. Can you observe all the pelvic disruption, all the damage? Okay. And the position of the cup, it's vertically. However, she walks. The CT scan is mandatory. I agree, totally agree, because the CT scan shows all the parts of the acetabulum walls compromised. Okay, points of treatment. Identification of the problem, stabilization and discontinuity, bone graft and the site of the continuity, treatment of any associated bone loss, placement of a stable acetabular implant. This is the most important point because in not all the cases it's possible to descend or down the rotation center. We need a very, very stabilization in the system, in the cups. And we'll fix it with the screws in these cases. In these graphics, I showed all the cases in the between systems for adequate fixation in the disruptive pelvic. It's very difficult. One option was the 3-flange, but very expensive, very, very expensive. And we decided for trabecular metal, the cup cage, for this case specifically. This is a Burch-Schneider ring, reinforcement ring, and the left side, the picture shows how is the fixation with the screws and the areas with the support in the acetabulum. We remove all in the surgery, how you can see, and you can, in the left picture, you can see all the defects and the dip of the dust defects. And we did put on the cup cage the reinforcement ring, Burch-Schneider, and we did put two dual mobility system, cemented. And in the whole, in this area, all is refilled with allograft. Was mixed, all the cup cage and the allograft. Was very difficult, not was possible to descend the rotational center, but was a stable fixation on the stem and the acetabular cup. It's, I want to tell you that these patients lose weight, very important, about 52, 53 kilos, how you can see. The last time I see her was 5 years. Is a very busy woman. Is not stable here in his visits, but no pain in that moment. Okay, for conclusion, I invite you to read these both articles. The system cup cage is a good option, not expensive in determinate cases, but it helps us for any cases in pelvic discontinuity. Thank you.
So, and right now, I would like to introduce Dr. Nicolás Restrepo, our organizer, with the speech, Acetabular defects treated with custom-made implants. Dr. Restrepo.
Thank you, Germán. It's a pleasure to be here. And right now we are talking about this innovative from SICOT to join all the nations. Thank you. We're going to talk about acetabular defects treated with custom-made implants. Marco does a good opening and introduction about difficult acetabular cases. But what is an acetabular case so difficult? Probably the difficult to restore the biomechanics. Yeah, in this case, it's difficult to have a good rotation, center of rotation. But almost every difficult case in acetabular have a reduced potential to bone healing. We have a bad bone, we're dealing with sclerosed bone. And what about the length optimization? It's difficult to get and correct this long leg discrepancy. Sometimes you have a severe bone loss. Just in this case, after this removal, we don't have anything to put in and to restore all the hips. And even worse, if it is infected. If you have infection, you have to remove more bone and you destroy probably all the acetabulum. And in these cases, 3A, 3B pelvis disruptions, they are difficult and inaccuracy to plan the reconstruction because sometimes you destroy more when you go to the OR. And it's to compare apples versus oranges. In these cases, 3A and 3B, the custom-made have a good options. And in pelvis disruptions, Even these parts, alloprosthesis, that we are not using anymore, plate, graft, and cups that is used for acute disruptions, arthro-distraction, triflange, and cup case, as our previous speakers have talked, we can use the custom-made as a good solution. What do we have available in almost every country? We use grafts, we can use trabecular metals, Marco shows excellent cases, and jumbo cups. And with this, we can handle probably the least serious ones, 2, 3, 3A, but some cases, like these ones, what these cases have in common? It's difficult to restore the biomechanics, and you need a preoperative planning after remove all these parts. You need a high quantity of bone grafts or trabecular metal, better trabecular metal, because if you use grafts, we have good, more failure rates, and these patients have multiple previous surgeries. So it's good to have the last resort to use these custom-made implants. Sometimes you can use solutions like this one, but I think you need a fundamental solution, and hopefully in the long term. This probably is a tumoral solution with short-length survival rates. We will revise the two searchers, Journal of Arthroplasty and PubMed. In this case, talking about these topics, two cases, 2 papers, but if you search about custom-made in acetabular reconstruction, you have more than almost 300 in the Journal of Arthroplasty, or more than 1,000 in PubMed. So it will be a good option to use a custom-made implant. And what does a custom-made prosthesis offer? It's like a tailor-made solution. We need to use minimum graft, and in case that you don't use more grafts, it's useful because it has lesser infection rates. The useful part of the custom-made is that like a final puzzle, the final piece of a puzzle. In this final piece, you put it and you restore biomechanics, correct length discrepancy, and it's a reproducible and fast surgery if you compare to put trabecular metal, grafts, plates, and all this stuff. The emerging role of 3D printings in arthroplasty and orthopedics is increasing. Right now, some service has its own 3D printing. It's not difficult to have it, and is used for acetabular reconstruction in fractures. And right now, we're using it as acetabular reconstruction in defects, even impossible to revise with conventional implants. This is a case specific to that you can try to create a 3 flange, like Marco told us, and you have all the possibilities to work this. In this case, you work with the technical supplier. You send the complete images, CT scans, 3D reconstruction, and you have interaction with the engineers. You can choose and decide how to make it. If you prefer to put a bigger cup or not so big cup to cover with the metal that you want, titanium, trabecular, whatever you want, and you decide how to put the screws, in which part you can use the screws. And once you finally, you have the authorization, the signature, to make the implant and to implant it. This is the case, a specific case, for example, when you have big destructions, you can have the preoperative situations when you decide to descend to the acetabular center of rotational, the right acetabular center of rotations. You have different options to put the screws, to use swings to put in the ischial, the pubic rams, and in this case, I specifically decide to put some screws down and not to perform the ischial part, even put screws in the ischium. It's easy in this case, and we work with the engineers to put this in case, begin our surgery, and as I told you, it's like put the final piece of the puzzle. If you need some grafts, you can put some grafts. In this case, the quantity of grafts are minimum, and I used to add vancomycin in these grafts, and like I told you, it's like you put the final piece. they have special templates when you are sure that your screws will be in the same part that you decide to put it, and you can choose to use cemented, uncemented, bipolar. In this case, in the future years, if it fails, you can remove this cup and put a new one. This is the case, the final case in this case. And if you see, as they are planned, probably is the final piece in this puzzle. And it's quite simple. This case, more difficult, infected, you have to remove that. And once you remove, you decide to do the custom-made implants. We decide to put a screw to the sacroiliacal part because we don't have anything to put it. And that's the final. It's quite the same. It's an easy to put than different trabecular metal and so on. Expensive, yeah, but right now the cost has decreased. We have in our own country the possibility to do it. In Argentina, it's cheaper, really. The cost benefit, because it's fast, we don't need grafts. In patients with infection, it will be better. And the take-home message is that in difficult case, you can compare apples with oranges and decide, I put this, or I do a retraction. Difficult situation, even when pelvic disruption, you need classical treatments that doesn't work easily. Repeated or difficult infection and severe bone loss is a good option to use it for this part. Thank you so much. This is our last talk, and right now the Ecuadorian president of the Ecuadorian Society, Dr. Pablo Cornejo, have to give a few words.
Thank you, Nicolás. And good morning for the Ecuador and good afternoon for the London. As the president for the Ecuadorian Orthopaedic Society, I good thanks to the Dr. Vikas Kanduja is the opportunity to have to Ecuador and SEOT-SICOT event. Thank you for much to the Nicolás and the other speakers, Ecuadorian speakers, Peruvian speakers, Mexican speakers, is the very good Charles. I hope to the first event, and I need to the more events in the Latin American. Thank you very much, Nicolás, and thank you very much for you.
Please, the presenters, the speakers, come here, please, if you have some questions. Any question from the audience here? Marco. Lo pueden hacer en español y la traducimos acá si quieren. Dr. Bracho.
Thank you, Nicolás. I would like to know if yo quisiera conocer si hay estudios a largo plazo, long-time studies, about the integration of the custom-made del sistema hecho a medida en cuanto a la integración ósea. Porque la idea, una de las ideas de los pilares, es que estos materiales que tienen una capacidad como de andamio para que se integren los osteoblastos, si hay estudios en ese sentido, si se llegan a integrar, si no se integran o si quedan como un material inerte, diríamos, o si se integran. Gracias. Thank you.
Dr. Bracho is asking about the possibility of osteointegration of the custom-made implants. The custom-made implants work so different, of the custom of the cup cage implants or the bone graft implants. In this case, when you have severe destructions, you can have like a hardware to cover all the defects, but really it's not integrated. It's like a cup. The surface goes to the bone and fix well, but there's no possibility to grow more bone. In some cases, they told us you can put grafts. You can put grafts and then a cup cage, for example, and these grafts will, in the future, probably reconstruct your pelvic part. But with this case, it's like a final solutions. It's only metal, and it fits well with the bone, with the remnant bone. But they have good result. More than 70, Marco told us, more than 70%, more than 6 years. And in some cases, Mayo Clinic and other hospitals, they have more than 82% for more than 10 years.
¿Cómo está, Nicolás? Pedro Faría desde Medellín. The question is, how do you think about the screw below the Ecuador? I see a big cup without a screw below the Ecuador. En español, esos tornillos por debajo del Ecuador, en copas grandes, si son necesarios o no son necesarios, porque uno ve esa radiografía y son copas muy grandes sin una fijación, si se puede decir, distal, y la mayoría de esas copas fallan en valgo. Se abren cuando el paciente empieza a apoyar, y si tienen algún tips para colocar el tornillo hacia el isquion o el tornillo hacia el pubis, y si vale la pena colocarlo o no vale la pena.
Dr. Pedro Farias from Colombia, Medellin, is talking about if it's helpful to put some screws in the ischial or pubic part in your reconstructions.
Well, talking about type 2 and type 3 defects, it's important to use multi-hole cups, not just a cluster cup. If you have a type 1 defect, it doesn't matter, but in big defects, it's important to get fixation as many screws as you can, especially going to the ischium, if it's possible, to the pubic bone. If not, it doesn't matter, but it's very important to try to fix the posterior column below the equator of the cup, and also to get enough fixation on the superior part. So the most screws, the better.
I totally agree with Marco, and even worse if you have a pelvic disruptions. If you have a pelvic disruption, you have to unite the lower part with the upper part, and that's the case because I don't like these cup case new constructions when they remove the ischial part of the Borges-Schneider cup. Yeah, there's place for one question, more question.
Tenemos una última pregunta en honor al tiempo, por favor, porque queremos que Nicolás nos dé su última una charla más.
Good morning, everyone. It's a question for Dr. Restrepo. I'm Yuri Lara from, I work in Barcelona, Spain. In custom-made implants, do you have any problem in the adjustment of the implant in the bone defect? Because at least in our first cases, we used to have problems when we saw the control X-rays. The custom-made implant is not adapted, and probably it's because of the soft tissue all around the bone. So I want to ask you about that.
I have some problems in the first cases because it takes long time to do it. The first case takes 8 months to do it, and once I go in, it's completely new bone. I have to look at the fluoroscopy and begin to resect bone. So the tip is that I use a big Rimmer cup 62 or 64, and I put under the fluoroscope to do where it will be seated. And then I begin to remove, and I use the wings the ischial and the pubic wings to control, and then I only put I used to go with the plastic, with the plastic first image, and they put it to try to begin removing, and then finally. But if you have less than 2 months, I don't have problem with that. Thank you so much for all your attention. Thank you.
Bien, agradecemos a todo el panel y queremos pedirle al auditorio, por favor, que nos vamos a tomar 10 minutitos más del coffee break, porque queremos que el doctor Nicolás Restrepo nos ayude con su conferencia, entendiendo la alineación mecánica y cinemática, conceptos puntuales.